Welcome to the Deep Dive, where we take a mountain of information, sift through it, and distill it into something truly insightful for you. Today, we're plunging headfirst into a substance that has woven itself into the very fabric of human history for at least 8,000 years. Alcohol. For millennia, it was more than just a drink. It was a main staple, a crucial source of calories, and a safer alternative to often questionable water sources. Now, for many, it's a social pastime, part of celebrations, a way to unwind.
It's truly fascinating how something so ancient, so seemingly simple, can have such profound and complex effects on the human body. I mean, from the individual cells that make us up, right through to entire organ systems. This deep dive will take us from the fundamental biochemistry all the way to the broad public health impacts, giving you a comprehensive understanding, just like an elite professional in this field would master it.
Right. Our mission today is to go far beyond the surface, beyond the headlines, and truly understand the pharmacology of ethanol. That's ethyl alcohol, the one we drink. We'll even delve into other types of alcohol that are highly toxic, which you might encounter in, say, industrial settings rather than a bar. You sent us incredibly detailed sources from a leading pharmacology text, and we're going to unpack every critical nugget. We want to explore not just what happens, but why it matters, and how these intricate mechanisms underpin both the pleasurable effects and the staggering societal and medical costs.
And to really ground our discussion, we'll use a very real, very tragic case study to bring the science to life. It's a powerful reminder of just how critical this understanding can be.
Absolutely. Okay, let's unpack this and get started. Imagine stepping back in time to a world before modern sanitation, before safe drinking water was readily available from every tap. For thousands of years, long before germ theory was even a whisper, people kind of understood that water could make them sick. So what did they turn to? Beer and wine. These fermented beverages were often preferred over water, not just for calories or some nutrients, but because the fermentation process itself partially sterilized them. It's almost impossible to overstate alcohol's role as a fundamental part of daily sustenance in Western society until, the 19th century.
That historical context is vital.
Yeah.
Absolutely. Our relationship with alcohol has fundamentally shifted. It moved from being a dietary staple, a necessity for hydration and calories, to primarily a recreational substance. And this change happened largely after the 19th century, coinciding with significant improvements in water purification. This transition profoundly altered how we perceive and interact with alcohol, laying the groundwork for many of the modern challenges we face with its widespread use.
Fast forward to today, and alcohol is undeniably widely consumed. In the U.S. alone, about 75% of adults drink regularly. In low to moderate amounts, it's known for its ability to relieve anxiety, to foster feelings of well-being, or even a sense of euphoria. It's that initial, often sought-after effect that makes it so popular and deeply integrated into social life.
But here's where the picture gets considerably more complex and frankly concerning. Despite its social acceptance, alcohol is also the most commonly abused drug globally, causing immense medical and societal costs. When we look at the numbers for the U.S. annually, we're talking about over 600,000 emergency department visits directly related to alcohol, and tragically, roughly 95,000 deaths. This positions alcohol as the third leading preventable cause of death in the United States.
Third leading. That's staggering.
It really is. These aren't just statistics. They represent immense human suffering and a significant burden on our healthcare systems and communities. Puts it in stark perspective alongside things like tobacco use.
Right. While most people can enjoy alcohol without significant health risks, a considerable portion of the population struggles. Roughly 8–10% of adults in the U.S. grapple with what's now broadly termed an alcohol use disorder. So when we talk about this struggle, what exactly are we defining?
That's an important distinction to make. We need to differentiate between what used to be called alcohol abuse and alcohol dependence, though these are now often grouped under the umbrella of alcohol use disorder in clinical diagnostic manuals. Alcohol abuse broadly refers to using alcohol in dangerous situations, think drinking and driving, or combining alcohol with medications in a way that poses a serious risk. It also includes continuing to drink despite experiencing clear adverse consequences directly linked to consumption, like, legal problems, strained relationships, or job loss.
And then there's the more severe, more entrenched form.
Precisely. What was previously termed alcohol dependence builds on those behaviors but adds a crucial component: physical dependence. This is key. It means the individual has developed tolerance, requiring increasingly larger amounts of alcohol to achieve the desired effect. And when they try to stop or reduce drinking, they experience withdrawal symptoms. Beyond the physical, individuals with dependence often lose control over their drinking. They might intend to have one drink, but find themselves unable to stop, consuming many more. They also devote significant time to obtaining alcohol, using it, or recovering from its effects. The compulsion really takes over much of their life.
It's rarely a simple choice, is it?
Yeah.
It's a complex picture, shaped by both a person's underlying genetic predispositions and a multitude of environmental factors.
Exactly. And we can't ignore the devastating long-term effects that extend far beyond the individual drinker. Chronic alcoholics often face poorer outcomes when hospitalized for other medical conditions, making their recovery much more challenging. Even more tragic is the impact on future generations. Tens of thousands of children are born annually with birth defects due to prenatal ethanol exposure. This is a spectrum of conditions collectively known as fetal alcohol spectrum disorders, with the most severe form being fetal alcohol syndrome, or FAS. This truly underscores the profound societal costs and the lasting shadow that widespread alcohol consumption casts.
Today, while our main focus is on ethanol, the alcohol we drink, it's really important to acknowledge that other alcohols exist, like methanol and ethylene glycol. These are widely used in industry and can be highly toxic if ingested. We'll delve into their specific dangers and treatments later, but for now, just know that these are not recreational substances, and accidental or intentional exposure to them can have catastrophic results. To bring this science to life, let's turn to a real-life scenario, a case study provided in our source material. Imagine a 19-year-old college freshman at a hazing event. This scenario tragically illustrates the acute, life-threatening dangers of excessive alcohol consumption, particularly for someone who hasn't developed tolerance. From 8:30 p.m. to midnight, he consumed beer, an entire bottle of whiskey, and then most of a bottle of rum. That's an enormous, rapidly consumed quantity for anyone, especially a young, likely non-tolerant individual.
That quantity is indeed staggering. So what happened next? The young man felt intensely nauseated, lay down, and began to lose consciousness. He was carried to a bedroom, placed on his stomach with a trash can nearby. Approximately 10 minutes later, he was found unresponsive, covered in vomit, and critically, not breathing. There was a tragic delay in treatment because the upperclassmen initially called college police instead of 911, which unfortunately postponed the rapid emergency medical response that was desperately needed. His blood alcohol concentration, measured shortly after he finally arrived at the hospital, was a staggering 510 milligdl.
510. Given that BAC, which is well above the lethal range for a non-tolerant individual, where even 300-400 milligdl can cause a coma, the cause of death becomes starkly clear. This isn't just high. It's a level that overwhelms and shuts down the body's most vital functions.
His death most likely resulted from severe respiratory and cardiovascular collapse. At such high concentrations, alcohol acts as a profound depressant on the central nervous system, effectively shutting down the brain centers that control fundamental actions like breathing and heart function. The presence of vomit also points to a critical complication: chemical pneumonitis due to aspiration. This means he essentially choked on his vomit, stomach contents entered his lungs, causing severe inflammation and further compromising his ability to breathe. Leading to suffocation on top of the systemic CNS depression, his airway was critically compromised.
Right, the aspiration is a huge factor. This brings us to a crucial point. If he had received medical care sooner, what specific treatments might have prevented his death? This is where understanding the immediate clinical response is absolutely vital, especially when dealing with such extreme overdoses.
The key here is immediate and aggressive supportive care, focusing on the fundamental ABCs of emergency medicine: airway, breathing, and circulation. For this young man, the first priority would have been securing his airway. This means intubating the trachea, inserting a breathing tube into his windpipe to ensure a clear passage for air, and crucially, to protect his lungs from further aspiration of vomit. Simultaneously, removing any vomitus from his mouth and airway would be critical. Then initiating mechanical ventilation to support or completely take over his breathing would be absolutely necessary, as his respiratory drive was so severely depressed.
So beyond getting air in, what else would be done? Getting that tube in place is step one.
Exactly. Beyond the ABCs, intravenous access would be established immediately to administer vital medications and fluids. This would include dextrose, a sugar solution, to quickly counteract hypoglycemia or dangerously low blood sugar, which frequently accompanies acute alcohol poisoning, because alcohol impairs the liver's ability to produce glucose. Thiamine, a B vitamin, would be given universally regardless of immediate symptoms to prevent Wernicke-Korsakoff syndrome, a serious neurological complication we'll discuss later. Finally, intravenous electrolyte solutions would be administered for rehydration and to correct any imbalances caused by the prolonged vomiting or metabolic disruptions.
This tragic case really underscores how understanding alcohol's effects and knowing how to respond can literally be a matter of life or death, especially in individuals like this freshman who haven't developed any tolerance. A rapid, informed medical response is paramount. So after hearing about the tragic consequences, let's pivot to understanding how alcohol actually moves through our system. We're going to get into the nitty-gritty of pharmacokinetics, which is essentially the body's journey with a drug, how it's absorbed, distributed, metabolized, and finally eliminated.
Ethanol, the alcohol we drink, is a relatively small water-soluble molecule. This makes it incredibly efficient at being absorbed, and it moves very rapidly from the gastrointestinal tract into the bloodstream. If you drink on an empty stomach, you'll typically reach peak blood alcohol concentrations within about 30 minutes. However, if there's food in your stomach, that significantly delays gastric emptying, meaning the alcohol takes longer to get from the stomach into the small intestine, where most absorption actually occurs, and therefore slows down its entry into your bloodstream.
Once it's absorbed, alcohol distributes rapidly throughout the body. Because it's so water-soluble and can easily cross cell membranes, its levels in tissues quickly begin to match its concentration in the blood. It spreads throughout your total body water, which gives it a relatively large volume of distribution, roughly 0.5 to 0.7 liters per kilogram of body weight.
What's particularly interesting and important to note is the sex-related difference in how alcohol affects people. Women often achieve a higher peak blood alcohol concentration than men after consuming an equivalent oral dose. This is partly because women generally have a lower total body water content relative to their body weight, meaning the same amount of alcohol is dissolved in a smaller volume, leading to a higher concentration. But also it's due to differences in first-pass metabolism, which we'll delve into next, where less alcohol is broken down before it even enters the main bloodstream.
Right. And because the brain receives a large proportion of your total blood flow, and ethanol so easily crosses the membranes that protect the central nervous system, its concentration in the brain rises very quickly. This explains the rapid onset of alcohol's mind-altering effects, from that initial buzz to profound intoxication.
After it's done its work, more than 90% of the alcohol you consume is primarily broken down or oxidized in the liver. A small but consistent proportion of the remaining alcohol is excreted unchanged through your lungs when you breathe out and in your urine. This pulmonary excretion, what you exhale, forms the basis for breath alcohol tests, which are the legal standard for defining driving under the influence in many countries, often at a blood alcohol level of 80 milligdl or 0.08% in the USA.
Now, here's where it gets really interesting and kind of unique to alcohol. Unlike many drugs, alcohol metabolism generally follows what's called zero-order kinetics at typical blood levels. This means your body metabolizes alcohol at a constant rate, largely independent of its concentration in your blood. It doesn't speed up or slow down much, even if you drink more. A typical adult can process about 7-10 grams of alcohol per hour. That's roughly one standard drink, whether it's 10 ounces of beer, 3.5 ounces of wine, or 1 ounce of 80-proof spirits. This constant rate is why things like exercising or drinking coffee won't magically help you burn off alcohol faster. Pacing is everything.
Exactly. And just as a side note, you might have heard of Palcohol, a powdered alcohol product approved in some states. When mixed, it contains about 10% ethanol, roughly equivalent to wine. It's just another form alcohol can take, but its core pharmacokinetic properties remain the same.
Our bodies are incredibly sophisticated, and they have developed multiple systems for dealing with alcohol. Let's break down the two main pathways your body uses to metabolize alcohol into a substance called acetaldehyde. This is laid out in figure 23:1 from our source material.
The first and primary pathway involves a family of enzymes called alcohol dehydrogenase, or ADH. These enzymes are found predominantly in the liver, but also in smaller amounts in the brain and stomach. ADH is responsible for directly converting alcohol into acetaldehyde. This is the crucial first step in your body's attempt to break down ethanol.
What's fascinating is the genetic variation within these ADH enzymes. For instance, there's a specific gene variant, the ADH1B2 allele, that leads to a much more rapid conversion of ethanol to acetaldehyde. This has been found to be protective against alcohol dependence, particularly in East Asian populations. The theory is that this faster production of acetaldehyde, which causes unpleasant effects, naturally deters individuals from consuming large amounts of alcohol.
This also directly connects to the sex differences in gastric alcohol metabolism we mentioned earlier. Women tend to have lower levels of ADH activity in their stomach lining. This means a smaller proportion of the alcohol is broken down in the stomach before it even reaches the liver, contributing to their higher peak blood alcohol concentrations compared to men, even when consuming the same dose.
A crucial byproduct of this conversion by ADH is the formation of NADH from NAD plus alum. Think of it like a chemical exhaust. This leads to an excess of what are called reducing equivalents in the liver. So why does this chemical buildup matter for your body's internal environment?
This excess NADH significantly contributes to several metabolic disorders commonly seen with chronic alcoholism, such as the accumulation of fat in the liver, known as fatty liver disease. More acutely, this imbalance contributes to both lactic acidosis, a dangerous buildup of lactic acid, and hypoglycemia, or dangerously low blood sugar, both of which frequently accompany acute alcohol poisoning, just as we saw with our freshman case study. The disruption of normal metabolic pathways due to this chemical imbalance is a major factor in alcohol's systemic toxicity.
The second major pathway is called the microsomal ethanol oxidizing system, or MEOS. This system uses a molecule called NADPH as a cofactor and primarily involves specific cytochrome P450 enzymes. These are enzymes like 2E1, 1A2, and 3A4, which become particularly active when someone drinks heavily.
What's particularly important here is that chronic, consistent alcohol consumption induces MEOS activity. This means the body adapts to regular alcohol intake by increasing the production and activity of these enzymes. As a result, chronic alcohol consumption not only increases the rate at which ethanol is metabolized, but also accelerates the clearance of other drugs that are broken down by these same cytochrome P450 enzymes. This has critical implications for drug interactions, where other medications might be cleared much faster than expected in chronic drinkers, reducing their effectiveness.
And it also leads to the generation of toxic byproducts like free radicals and hydrogen peroxide, which are highly reactive molecules that cause damage to cells and tissues, especially in the liver. This oxidative stress is a key mechanism behind much of the organ damage caused by alcohol.
So we have alcohol being broken down into acetaldehyde by both ADH and MEOS. But here's the thing. Acetaldehyde itself is highly toxic. So the body has a third critical metabolic process, an enzyme called aldehyde dehydrogenase, or ALDH. This enzyme is primarily found in the liver's mitochondria, the powerhouses of your cells, and it converts acetaldehyde into acetate. Acetate is much less harmful and can then be further broken down into carbon dioxide and water, or used to form acetyl-CoA, which enters general metabolic pathways to produce energy.
This is where pharmacology can actually intervene. The drug disulfiram directly inhibits aldehyde dehydrogenase. When someone taking disulfiram consumes alcohol, acetaldehyde builds up rapidly because it can't be broken down into harmless acetate. This causes a profoundly unpleasant reaction: intense facial flushing, a throbbing headache, severe nausea, vomiting, sweating, dizziness, and a drop in blood pressure. It's a highly aversive experience, and it's been used as a deterrent in alcoholism treatment.
And it's not just disulfiram. This raises an important question. Are there other drugs that can cause this reaction? Yes, some other common medications like metronidazole, an antibiotic, cefotetin, and trimethoprim can also inhibit ALDH and cause a similar disulfiram-like reaction if combined with ethanol. This is important for clinicians and patients to be aware of, as these reactions can be accidental.
And just as we saw with ADH, there's a significant genetic component here too. Some people, predominantly of East Asian descent, have a genetic deficiency in mitochondrial ALDH activity, specifically linked to the ALDH2 gene. When they drink, they naturally experience high blood acetaldehyde concentrations, similar to what happens when someone takes disulfiram. This causes that same noxious reaction, which is strongly protective against alcohol use disorders in these populations, as the immediate discomfort deters heavy drinking. Let's shift from how alcohol is processed to what it actually does to us, moment by moment, starting with the brain, our central nervous system, or CNS.
Acute alcohol consumption profoundly affects the CNS. At lower concentrations, it causes sedation and anxiety relief, which are often the sought-after effects. But as blood levels rise, the effects become more pronounced and concerning. Slurred speech, ataxia or impaired coordination, impaired judgment, and disinhibited behavior, what we commonly call being intoxicated or drunk. These effects are progressive and directly related to the dose.
It's important to note that these effects are actually most marked as the blood alcohol level is rising. This is because acute tolerance can occur after just a few hours of drinking. What this means is that a person might feel more intoxicated at a certain BAC as they're drinking compared to the same BAC as their body is metabolizing the alcohol and the level is coming back down.
What's truly striking here is the stark difference in tolerance between individuals. Someone with chronic alcoholism might appear relatively sober or only mildly intoxicated at a BAC of 300-400 mg/dL, a level that would cause marked intoxication, coma, or even death in someone who isn't tolerant, like our freshman from the case study. This really highlights the body's remarkable yet ultimately limited ability to adapt to chronic exposure.
And the real-world consequences are tragically clear. 30–40% of all fatal traffic accidents in the U.S. involve at least one person with a blood alcohol level near or above the legal limit. This makes drunken driving a leading cause of death in young adults, a devastating yet entirely preventable public health issue.
Ultimately, alcohol is a powerful CNS depressant. At very high concentrations, it induces a deep coma, severe respiratory depression, and ultimately death. This is precisely what happened to our freshman, and it underscores why understanding these dose-dependent effects is so critical.
Okay, let's unpack this a bit more deeply. How exactly does alcohol exert these profound effects at a molecular level within the brain? It's not just a general depressant, it's actually interacting with specific cellular machinery.
Ethanol influences a vast array of membrane proteins involved in the brain's signaling pathways. While it touches many systems, much of the scientific attention focuses on its profound effects on glutamate and GABA. These are the brain's two main workhorse neurotransmitters. Glutamate is primarily excitatory, acting like the brain's accelerator, while GABA is primarily inhibitory, acting like the brain's brakes. Their delicate balance is crucial for normal brain function and mood regulation.
So what does this all mean for their activity? Acute ethanol exposure enhances the action of GABA at its specific GABA receptors. This effectively puts the brakes on brain activity, explaining why alcohol causes sedation, anxiety relief, and slowed thinking. It also explains why drugs that mimic or enhance GABA, like benzodiazepines, intensify alcohol's effects, leading to even more profound sedation and dangerous respiratory depression.
Conversely, ethanol inhibits glutamate's ability to activate its specific NMDA receptors. Since NMDA receptors are absolutely crucial for vital cognitive functions like learning and memory formation, this inhibition may be the molecular basis for blackouts. Those periods of memory loss that can occur at high alcohol levels, the brain simply can't form new memories effectively when these crucial receptors are blocked.
And here's where cutting-edge genetic approaches, even using surprising model organisms, are revealing even more about alcohol's targets and confirming some long-held hypotheses about its mechanisms.
Right. It's incredibly challenging to pinpoint alcohol's precise targets because it's a relatively non-specific drug that affects so many systems. That's where genetic research and experimental animals comes in, providing invaluable insights. Researchers have, for instance, identified mouse strains with abnormal ethanol sensitivity through breeding programs. By using sophisticated genetic mapping and sequencing, they've identified specific genes that either confer susceptibility or resistance to alcohol's effects.
A more targeted approach uses transgenic mice. For example, earlier experiments hinted at a link between a brain neuropeptide called NPY and ethanol. Researchers then found that mice lacking the gene NPY knockout mice actually consume more alcohol and are less sensitive to its sedating effects. Conversely, mice that overexpress NPY drink less, suggesting that NPY might be a key player in regulating alcohol consumption and vulnerability to its effects.
This kind of work supports the central role of well-known signaling systems like those involving GABA, glutamate, dopamine, opioid, and serotonin receptors, which have long been believed to be involved in alcohol's effects and addiction pathways. While doing so, it also builds the case for newer candidates like NPY, corticotropin-releasing hormone, CRF, cannabinoid receptors, various ion channels, and protein kinase C, significantly broadening our understanding of alcohol's molecular footprint.
And it's not just mice. It's easy to imagine mice responding to alcohol, but drunken worms and fruit flies. That sounds almost comical.
Surprisingly, both Drosophila melanogaster, our common fruit flies, and Canarhabditis elegans, tiny worms, show ethanol responses that remarkably parallel what we see in mammals. Flies, for instance, exhibit increased locomotion at low concentrations, a kind of initial excitation, almost a buzz. But at higher concentrations, they become poorly coordinated, sedated, and finally immobile. Worms show similar patterns, with increased locomotion at low doses and reduced movement and sedation at higher levels. The impaired egg laying at high concentrations in worms provides an effective and easily scorable screen for resistant mutants.
The significant advantage of these invertebrate models is their relatively simple neuroanatomy, which makes studying neural circuits much easier than in complex mammalian brains. They also have well-established techniques for genetic manipulation, extensive mutant libraries that allow researchers to study specific gene functions, and fully or nearly fully sequenced genomes. This genetic tractability allows for rapid and precise experimentation that's often much more difficult and time-consuming in, say, mammals.
Indeed. An elegant study on C. elegans even provided direct evidence that a specific calcium-activated voltage-gated BK potassium channel is a direct target of ethanol, affecting how neurons fire. Similar effects were observed in homologs of this channel in flies and vertebrates, suggesting a conserved mechanism across species. These genetic experiments are crucial for narrowing down the incredibly complex effects of ethanol in humans, moving beyond broad theories to pinpointing specific molecular targets.
Beyond the brain, alcohol also has immediate acute effects on other vital systems in the body.
On the heart, significant depression of myocardial contractility, meaning alcohol directly weakens the heart's pumping ability, has been observed at blood alcohol concentrations above 100 mg/L. This is a level often considered intoxicated, but not necessarily life-threatening on its own.
As for smooth muscle, ethanol is a powerful vasodilator, meaning it causes blood vessels to widen. This happens due to both its effects on the CNS, depressing the vasomotor center that regulates vessel constriction, and direct smooth muscle relaxation caused by its metabolite, acetaldehyde. In severe overdose, this widespread vasodilation can lead to marked hypothermia or dangerously low body temperature, especially if the individual is in a cold environment as the body loses heat much more rapidly.
There's even preliminary evidence that flibanserin, a drug that interacts with serotonin receptors, can significantly augment alcohol's hypotensive effects, potentially causing severe orthostatic hypertension and syncope or fainting when someone stands up quickly. This highlights another potentially dangerous drug interaction.
And historically, it's quite surprising. Before safer and more effective uterine relaxants like calcium channel antagonists were introduced, ethanol was actually used intravenously to suppress premature labor. While certainly not a common practice today due to its risks, it showcases alcohol's powerful, smooth, muscle-relaxing properties.
To bring all these acute effects together, let's quickly revisit the table outlining blood alcohol concentration and its typical clinical effects in non-tolerant individuals. This provides a clear, progressive dose-response picture.
Right. At 5,100 mg/dL, you typically experience sedation, a subjective feeling of being high, and slower reaction times. This is the range where most people cross the legal DUI threshold. Moving up to 100-200 mg/dL, you see clearer signs of intoxication, impaired motor function, slurred speech, and ataxia, that loss of coordination. Moving up to 100-200 mg/dL, you see clearer signs of intoxication. At 200-300 mg/dL, this level often leads to emesis or vomiting, and stupor, a state of near unconsciousness. Moving up to 100-200 mg/dL, you see clear signs of intoxication. At 300-400 mg/dL, coma is expected in a non-tolerant individual. Moving up to 100-200 mg/dL, you see clearer signs of intoxication. And finally, above 400 mg/dL, as we saw with our freshmen, this is the critical life-threatening range, leading to severe respiratory depression and ultimately death.
It's a stark reminder of the escalating risks as BAC rises, underscoring why rapid medical intervention is so crucial in cases of severe acute intoxication.
While acute intoxication can be immediately dangerous, the chronic, long-term consumption of alcohol profoundly impacts nearly every vital organ in your body. The damage accumulates over time, leading to a host of debilitating and often irreversible conditions.
It's fascinating and tragic to consider why ethanol causes so much tissue damage. Because of its relatively low potency compared to other misused drugs like cocaine or opiates, it requires concentrations thousands of times higher to produce its intoxicating effects. This means it's consumed in unusually large pharmacological quantities, imposing a massive and relentless metabolic burden on the body, especially the liver.
The widespread tissue damage stems from a complex interplay. Alcohol's direct toxic effects on cells, the toxicity of its primary metabolite, acetaldehyde, and the sheer metabolic consequences of processing such a heavy load of a metabolically active substance day in and day out.
Specific mechanisms implicated include increased oxidative stress coupled with the depletion of glutathione, which is one of the body's critical antioxidant defenses. There is also direct damage to mitochondria, the powerhouses of our cells, dysregulation of growth factors essential for tissue repair, and the potentiation of cytokine-induced injury, meaning alcohol amplifies the body's inflammatory response. Overall, chronic heavy alcohol consumption is strongly associated with a significantly increased risk of death from liver disease, various cancers, accidents, and suicide. It paints a grim picture of its long-term toll. Let's start with the liver and gastrointestinal tract, which are truly ground zero for alcohol-related damage. Liver disease is the most common medical complication of chronic alcohol abuse, affecting an estimated 15–30% of chronic heavy drinkers.
So how does this damage typically progress? It usually starts as alcoholic fatty liver, a condition where fat accumulates in liver cells. The good news is that this is often reversible if drinking stops early. However, if alcohol consumption continues, it can advance to alcoholic hepatitis, which is characterized by inflammation and widespread liver cell death. And this can then progress to irreversible cirrhosis and liver failure. In the U.S., chronic alcohol abuse is the leading cause of liver cirrhosis and, tragically, the most common reason for needing a liver transplantation.
The risk for liver damage is directly related to the average daily amount and duration of alcohol abuse. It's a cumulative effect. Women, even at lower consumption levels, appear to be more susceptible to alcohol-induced liver toxicity than men, and having co-infection with hepatitis B or C viruses significantly increases the risk, creating a dangerous synergy.
Cirrhosis itself leads to severe complications. One of the most dangerous is elevated portal blood pressure, a condition called portal hypertension, which in turn causes dangerous esophageal and gastric varices. These are enlarged, fragile veins in the esophagus and stomach that can rupture and cause massive, life-threatening bleeding.
The pathogenesis of alcoholic liver disease is incredibly multifactorial. It involves metabolic issues stemming from ethanol oxidation, dysregulation of fatty acid metabolism, and, crucially, activation of the innate immune system. This immune activation happens due to a combination of alcohol's direct effects and bacterial endotoxins that can leak into the liver from alcohol-induced changes in the gut, which compromises the intestinal barrier. A pro-inflammatory signaling molecule called tumor necrosis factor alpha, TNFC, appears to play a pivotal role in the progression of alcoholic liver disease, making it a potential therapeutic target for future treatments.
Beyond the liver, other parts of the gastrointestinal tract are also significantly injured. Chronic pancreatitis, a painful and debilitating inflammation of the pancreas, is most commonly caused by alcohol in the Western world. This is due to both direct toxic effects on pancreatic cells and by promoting the formation of protein plugs and calcium carbonate-containing stones within the pancreatic ducts, blocking the flow of digestive enzymes.
Chronic alcoholics are also prone to gastritis and inflammation of the stomach lining. They can also have increased susceptibility to protein loss, which may contribute to anemia and protein malnutrition. Alcohol directly injures the small intestine as well, leading to diarrhea, weight loss, and deficiencies in multiple vitamins, especially water-soluble vitamins like folic acid and thiamine. This malabsorption further compounds the nutritional deficits.
Next, let's turn to the nervous system, which, as we discussed with acute intoxication, is affected both immediately and profoundly over the long term. Chronic, high-dose alcohol use leads to significant tolerance and both physical and psychological dependence.
Let's delve into tolerance and dependence. Tolerance to alcohol's intoxicating effects is a complex process. It involves not fully understood changes in the nervous system, as well as the pharmacokinetic changes we discussed earlier, such as the induction of the MEOS pathway. Crucially, this tolerance isn't absolute. There's only a relatively small increase in the lethal dose with increased use. This means a chronic drinker can still reach dangerous, even fatal BACs.
The existence of physical dependence is most starkly revealed by the alcohol withdrawal syndrome, which occurs when chronic drinkers suddenly reduce or completely stop consumption. This is a clear indicator that the body has adapted to the continuous presence of alcohol and struggles intensely to function without it.
This withdrawal syndrome can range from mild hyperexcitability to severe manifestations like seizures, toxic psychosis, and delirium tremens. Delirium tremens, often called the DTs, is a particularly severe and potentially fatal form of withdrawal. It's characterized by profound shaking, intense confusion, high blood pressure, fever, terrifying hallucinations, and sometimes even death. The intensity of withdrawal generally correlates with the dose, rate, and duration of alcohol consumption. Even just reducing intake, not just complete cessation, can trigger significant withdrawal signs in heavy drinkers, making it incredibly difficult for them to cut back safely without medical supervision.
Psychological dependence, on the other hand, is a compulsive desire for alcohol's rewarding effects, or for current drinkers, a powerful urge to avoid the profound unpleasantness of withdrawal. Even after a period of abstinence, intense cravings can be triggered by environmental cues, familiar places, people, or events associated with past drinking. This explains why relapse is such a persistent and challenging obstacle in recovery.
What's truly fascinating here is exploring the molecular basis of tolerance and dependence. While it's not fully understood, tolerance might be due to an upregulation of certain brain pathways in response to continuous ethanol presence, almost like the brain turning up the volume to compensate for alcohol's dampening effect. Dependence, conversely, might be due to the overactivity of these same pathways when ethanol dissipates before the system can return to normal, leading to that profound hyperexcitability.
Chronic alcohol exposure triggers many adaptive responses involving neurotransmitters, their receptors, ion channels, and various signaling pathways. For example, the upregulation of NMDA glutamate receptors, those accelerator receptors we discussed earlier, and voltage-sensitive calcium channels may underlie the seizures that frequently accompany the alcohol withdrawal syndrome, as the brain's excitatory system becomes dangerously overactive.
GABA neurotransmission, the brain's brakes, is also pivotal in tolerance and withdrawal. Firstly, sedative hypnotic drugs that enhance GABAergic neurotransmission, like benzodiazepines, can effectively substitute for alcohol during withdrawal, providing a mechanism for safe detoxification by calming the overactive brain. Secondly, there's evidence that chronic alcohol exposure leads to a downregulation of GABA-mediated responses, meaning the brain becomes less responsive to its own inhibitory signals, further contributing to the hyperexcitability of withdrawal.
Like other drugs of abuse, ethanol profoundly modulates the brain's mesolimbic dopamine reward circuit, increasing dopamine release in the nucleus accumbens. This area is often called the brain's pleasure center, reinforcing drinking behavior. Alcohol also affects local concentrations of serotonin, endorphins, and endocannabinoids, all neurotransmitters deeply involved in the brain's reward system. So what does this all mean for developing effective treatments?
Well, the fact that naltrexone, an opioid receptor antagonist, helps patients recovering from alcoholism supports the idea of a shared neurochemical reward system across different drugs of dependence, suggesting that common pathways can indeed be targeted therapeutically. Animal models further show that cannabinoid CB1 receptor antagonists can reduce ethanol intake, opening exciting new avenues for research. Beyond these, two other neuroendocrine systems, the appetite-regulating system, involving peptides like leptin, ghrelin, and neuropeptide Y, and the stress response system, controlled by corticotropin-releasing factor, also play key roles in modulating ethanol-seeking behavior in animal models. This points to a complex multi-system interplay influencing addiction. Moving from functional changes to more permanent structural damage, neurotoxicity is another serious long-term consequence. Consuming large amounts of alcohol over many years can lead to significant and often irreversible neurological deficits. The most common is generalized symmetric peripheral nerve injury, often starting with tingling in the hands and feet, progressing to numbness and weakness. Degenerative changes can also cause gait disturbances and ataxia, making walking difficult and unsteady. Less commonly, but more severely, long-term alcohol use can lead to dementia and demyelinating disease, where the protective sheath around nerve fibers is damaged, impairing nerve signaling.
And then there's a particularly serious condition, Wernicke-Korsakoff syndrome, which is truly a medical emergency.
Yes, this relatively uncommon but critical entity is characterized by a triad of symptoms: paralysis of external eye muscles, ataxia, and a confused state that can tragically progress to hallucinations, confabulations, coma, and even death. It's strongly associated with thiamine, vitamin B1 deficiency, which is common in alcoholism due to malnutrition and malabsorption, though it can also appear in gastric bypass patients. All patients with suspected Wernicke-Korsakoff or any altered consciousness or seizures suggestive of it must receive thiamine therapy immediately. Often, the ocular signs, ataxia, and acute confusion improve promptly upon administration of thiamine. However, most patients are sadly left with Korsakoff psychosis, a chronic disabling memory disorder that permanently impairs their ability to form new memories.
Chronic alcohol use can also impair visual acuity, causing a painless blurring that develops over several weeks. These changes are usually bilateral and symmetric and may eventually lead to optic nerve degeneration, resulting in permanent vision loss. It's important to note that this is distinct from the severe and acute visual disturbances caused by methanol ingestion, which we'll cover shortly.
Let's consider the cardiovascular system. Alcohol has truly complex effects here. It's a genuine double-edged sword.
First, cardiomyopathy and heart failure. Heavy, long-duration alcohol consumption is firmly linked to dilated cardiomyopathy, a condition where the heart muscle becomes weakened and enlarged. with ventricular hypertrophy, meaning a thickening of the heart walls, and fibrosis or scarring. At the cellular level, this involves cardiac membrane disruption, depressed mitochondrial and sarcoplasmic reticulum function, and intracellular accumulation of phospholipids and fatty acids, all severely impairing the heart's ability to pump blood effectively.
Interestingly, patients with alcohol-induced cardiomyopathy tend to fare significantly worse than those with other forms, especially if they continue drinking. This is partly because ethanol can interfere with the beneficial effects of crucial heart medications like beta blockers and ACE inhibitors. However, on a positive note, cessation of drinking is often associated with improved cardiac size and function, offering hope for recovery.
Second, arrhythmias. Both heavy drinking and particularly binge drinking are strongly associated with atrial and ventricular arrhythmias, irregular heartbeats that can be dangerous. During alcohol withdrawal, severe arrhythmias can develop, reflecting issues with potassium or magnesium metabolism and enhanced catecholamine release, which can overstimulate the heart. These arrhythmias can contribute directly to seizures, syncope, fainting, and sudden death during withdrawal.
Third, hypertension. There's a fun epidemiological link between heavier alcohol consumption, generally defined as more than 3 drinks per day, and hypertension, or high blood pressure. Alcohol is estimated to be responsible for about 5% of all hypertension cases, independent of other factors like obesity, salt intake, or smoking. The good news here is that reducing alcohol intake can effectively lower blood pressure in heavy drinkers, and their hypertension also responds well to standard blood pressure medications.
Fourth, coronary heart disease, CHD. This is where the double-edged sword aspect truly emerges. Despite the known deleterious effects of excessive alcohol, there's strong epidemiological evidence that moderate alcohol consumption may actually prevent coronary heart disease, ischemic stroke, and peripheral arterial disease. This fascinating relationship where there's a potential benefit at low doses but clear harm at high doses is famously known as a J-shaped relationship.
So what does this all mean for the proposed mechanisms behind this J-shaped curve? Alcohol's ability to raise HDL, the good cholesterol, is a key factor, as HDL appears to protect against atherosclerosis, the hardening of arteries. It also inhibits inflammatory processes that lead to atherosclerosis and increases the production of the natural anticoagulant tissue plasminogen activator, TPA, which helps dissolve blood clots. Some alcoholic beverages, like red wine, also contain antioxidants, such as resveratrol and ellagic acid, which may be protective.
However, it's crucial to remember that this positive association is based on observational studies, which can show correlations but not definitively prove cause and effect. Randomized clinical trials, which are the gold standard for proving causality, have not been carried out to examine the benefit of moderate alcohol consumption in CHD prevention. So, while intriguing, it's generally not a recommendation for non-drinkers to start drinking for heart health.
In terms of blood, alcohol indirectly affects hematopoiesis, the production of blood cells, through metabolic and nutritional deficits, which are common in chronic drinkers. It may also directly inhibit bone marrow cell proliferation, further impairing blood cell production.
The most common blood disorder in chronic drinkers is a mild anemia, often due to folic acid deficiency, which is a very common vitamin deficiency in alcoholics. Iron deficiency anemia can result from chronic gastrointestinal bleeding. Alcohol also contributes to several hemolytic syndromes, where red blood cells are prematurely destroyed, some linked to hyperlipidemia and severe liver disease.
Let's also look at the endocrine system and electrolyte balance. Chronic alcohol use significantly impacts both hormonal regulation and fluid and electrolyte balance throughout the body.
Clinical reports show gynecomastia, or breast enlargement in men, and testicular atrophy in alcoholics, suggesting a significant derangement in steroid hormone balance, likely affecting testosterone and estrogen levels.
Patients with chronic liver disease often have profound fluid and electrolyte imbalances, including ascites, which is fluid accumulation in the abdomen, generalized edema, and effusions, which are fluid accumulations in body cavities like the lungs. Whole body potassium alterations from vomiting and diarrhea, along with severe secondary aldosteronism, a hormonal imbalance that causes the body to retain sodium and water while excessively excreting potassium, can contribute significantly to muscle weakness and can be worsened by diuretic therapy.
And the metabolic derangements from processing large amounts of ethanol can lead to hypoglycemia, or dangerously low blood sugar, due to impaired hepatic gluconeogenesis, which is the liver's ability to produce new glucose. It could also cause ketosis, an accumulation of ketones, caused by excessive lipolytic factors, particularly increased cortisol and growth hormone.
A profoundly serious long-term consequence, which we touched upon earlier, is fetal alcohol syndrome, FAS. Chronic maternal alcohol abuse during pregnancy is a leading cause of mental retardation and congenital malformation due to its direct teratogenic or birth defect-causing effects.
The characteristic abnormalities of FAS include intrauterine growth retardation, where the baby doesn't grow well in the womb, microcephaly, an abnormally small head, poor coordination, an underdeveloped midfacial region appearing as a flattened face, and minor joint anomalies. More severe cases can include congenital heart defects and profound mental retardation. While high levels of alcohol intake are definitively linked to these severe deficits, the threshold for more subtle neurological deficits, often referred to as fetal alcohol spectrum disorders, remains uncertain. The consensus is that any amount of alcohol during pregnancy carries some risk.
What's particularly fascinating and concerning, here's the mechanism. Ethanol rapidly crosses the placenta, reaching similar concentrations in the fetus as in the mother's blood, meaning the fetus is exposed to the same harmful levels. Critically, the fetal liver has little to no alcohol dehydrogenase activity, so the fetus depends entirely on maternal and placental enzymes for alcohol elimination. This means alcohol lingers in the fetal system for much longer, prolonging the exposure to its toxic effects.
Neuropathological studies in humans and animal models indicate that ethanol directly triggers apoptotic neurodegeneration, which is a programmed cell death of neurons, and causes aberrant neuronal and glial migration in the developing nervous system. These are critical processes for proper brain formation and wiring. In tissue culture, ethanol strikingly reduces neurite outgrowth, which is the growth of projections from nerve cells, thereby disrupting proper brain development.
Next, let's explore the immune system. Alcohol's effects here are quite complex, leading to inhibition in some tissues and pathological hyperactivity in others.
Indeed, acute and chronic exposure can have vastly different immune effects. In the lungs, for instance, we see a suppression of alveolar macrophage function. Macrophages are critical immune cells that clear pathogens. There's also an inhibition of granulocyte chemotaxis, which is the movement of white blood cells to infection sites, and a reduced number and function of T cells, which are key components of adaptive immunity. All of these effects severely impair the lung's ability to fight infection.
In the liver, however, there's an enhanced function of innate immune cells like Kupffer cells, which are resident liver macrophages, and hepatic stellate cells, which contribute to scarring. This leads to increased cytokine production, which are inflammatory molecules, contributing to the severe liver damage we discussed earlier.
So what does this all mean for overall health? Beyond the inflammatory damage in the liver and pancreas, chronic heavy alcohol use significantly predisposes individuals to infections, especially lung infections. This worsens their overall condition and significantly increases mortality risk for patients with pneumonia, as their weakened immune response leaves them more vulnerable.
Finally, increased risk of cancer is a silent but very serious long-term threat. Chronic alcohol use significantly increases the risk for cancers of the mouth, pharynx, larynx, esophagus, and liver. There's also mounting evidence suggesting a small increase in breast cancer risk in women.
A clear threshold level for alcohol consumption in cancer hasn't been definitively determined, meaning even moderate drinking might carry some level of risk. Interestingly, alcohol itself doesn't appear to be a direct carcinogen in most test systems.
This raises an important question. Why the strong link, then? It's primarily its toxic metabolite, acetaldehyde, which can directly damage DNA, leading to mutations. Also, the reactive oxygen species produced by increased cytochrome P450 activity play a role, along with changes in folate metabolism and the growth-promoting effects of chronic inflammation, which can create an environment conducive to cancer development over time.
Alcohol doesn't just act alone in the body. It can significantly alter how other drugs behave, leading to potentially dangerous interactions. These interactions can occur through changes in pharmacokinetics, which is how the body processes the drug, or pharmacodynamics, which is how the drugs affect the body's systems.
The most common pharmacokinetic interactions result from alcohol-induced increases in drug-metabolizing enzymes. Prolonged chronic alcohol intake, even without overt liver damage, can induce the microsomal ethanol oxidizing system, or MEOS, which, as we discussed, enhances the breakdown of other drugs that use the same enzyme pathways. This can lead to a reduced effect of those drugs, as they're cleared from the body more quickly than expected.
This is particularly important with acetaminophen, a common pain reliever found in many over-the-counter medications. Chronic consumption of 3 or more alcoholic drinks per day significantly increases the risk of hepatotoxicity, or liver damage, from even toxic or high therapeutic levels of acetaminophen. So what does this all mean for someone casually taking Tylenol after a night of drinking? It's because increased P450 activity, specifically the MEOS enzymes, converts acetaminophen into reactive toxic metabolites that directly damage liver cells. The FDA even requires warnings on over-the-counter acetaminophen products about this specific risk.
Conversely, acute alcohol use a single episode or short-term heavy drinking can actually inhibit the metabolism of other drugs. This happens by either directly competing for the same enzyme activity or by decreasing liver blood flow. This interaction is clinically significant for drugs like phenothiazines, tricyclic antidepressants, and other sedative hypnotic drugs, leading to prolonged and potentially exaggerated effects of these medications because they stay in the body longer.
Beyond how drugs are processed, pharmacodynamic interactions are also of great clinical significance. This is simply where alcohol adds to or amplifies the effects of other medications at their site of action.
The most crucial interaction is the additive central nervous system depression that occurs when alcohol is combined with other CNS depressants, especially sedative hypnotics like benzodiazepines or opioids. This combination can be extremely dangerous, leading to profound sedation, severe respiratory depression, coma, and even death, as the depressive effects are multiplied, not just added together.
Alcohol also potentiates the pharmacological effects of many non-sedative drugs, including vasodilators, which widen blood vessels, and oral hypoglycemic agents, which lower blood sugar. This can lead to potentially hazardous outcomes like dangerously low blood pressure or dangerously low blood sugar, even if the other medication is taken at its normal therapeutic dose.
Alcohol remains a leading cause of preventable morbidity and mortality globally, second only to tobacco in its profound impact on public health.
So what does this all mean for daily life and understanding what's considered risky drinking? Epidemiologic studies provide crucial guidelines. For men under 65, the risk for alcohol-related problems significantly increases with more than 4 standard drinks on any single day, or over 14 drinks per week. For women and men over 65, the threshold is lower, indicating greater vulnerability. More than 3 drinks in a single day or 7 drinks per week. These are crucial guidelines for assessing individual risk.
While traditional factors like personality, life stresses, psychiatric disorders, and parental role models haven't been reliable predictors of alcohol abuse individually, evidence points to a very significant genetic contribution. Polymorphisms or common variations in alcohol dehydrogenase and aldehyde dehydrogenase genes that lead to increased aldehyde accumulation and those unpleasant reactions, like facial flushing and nausea, appear to be protective against alcoholism. Individuals with these genetic variations are naturally deterred by these immediate adverse effects.
Conversely, polymorphisms associated with a relative insensitivity to alcohol and therefore a potentially greater risk of abuse have been identified in genes encoding various receptors and enzymes, like an alpha subunit of the GABA receptor, an M2 muscarinic receptor, a serotonin transporter, adenyl cyclase, and a potassium channel. These genetic variations may make individuals less sensitive to alcohol's negative effects, leading them to consume more alcohol to achieve the desired effect, increasing their risk for developing an alcohol use disorder.
What's truly fascinating here is the potential for genotype-guided pharmacotherapy. For example, researchers have identified a polymorphism in an opioid receptor gene that's linked to a blunted response to naltrexone. This suggests that in the future, we might be able to tailor alcoholism treatments based on an individual's specific genetic makeup, optimizing their chances of success with a particular medication.
Returning to our case study of the college freshman, let's now look at the immediate medical management of acute alcohol intoxication. This knowledge can literally be the difference between life and death.
The primary goals in managing acute alcohol intoxication are to prevent severe respiratory depression and the aspiration of vomitus, as these are the most immediate and life-threatening complications. Even with very high blood ethanol levels, survival is probable if the respiratory and cardiovascular systems can be aggressively supported through intensive medical care. While the average fatal BAC is typically above 400 mg/dL, it's crucial to remember that the lethal dose varies significantly due to individual differences in tolerance.
Beyond basic life support, correcting electrolyte imbalances is often necessary, as prolonged vomiting and metabolic disturbances can cause significant shifts in the body's mineral balance. Metabolic alterations, particularly hypoglycemia, or dangerously low blood sugar, and ketoacidosis, require prompt treatment with glucose administration to restore normal metabolic function.
Thiamine is universally given to protect against Wernicke-Korsakoff syndrome, regardless of whether immediate symptoms are present. This is due to its critical importance in preventing this devastating neurological condition. Patients who are dehydrated and vomiting also need intravenous electrolyte solutions for rehydration, and if vomiting is severe, large amounts of potassium may be required, provided renal function is normal, to prevent potentially fatal cardiac arrhythmias.
Once the immediate crisis of acute intoxication is over, particularly in chronic drinkers, the concern shifts to managing the alcohol withdrawal syndrome, which requires careful medical oversight to stabilize the brain and body.
Abrupt discontinuation of alcohol in a dependent individual leads to a characteristic syndrome of motor agitation, anxiety, insomnia, and a significantly reduced seizure threshold. Its severity generally correlates with the degree and duration of alcohol abuse, though other factors like the use of other sedatives or coexisting medical conditions can significantly modify its presentation.
Let's look at the typical time course, which is critical for professionals to understand, as shown in Figure 23.2. Within 6-8 hours after stopping alcohol, milder symptoms like an increased pulse and blood pressure, tremor, anxiety, and insomnia typically begin. These usually lessen within 1-2 days, though anxiety and sleep disturbances can persist for months. Within the first 1 to 5 days, more severe acute reactions can occur, such as withdrawal seizures, which are a common cause of adult seizures, or alcoholic hallucinations. Several days later, typically 48-72 hours after discontinuation, individuals can develop delirium tremens.
Right, the DTs, characterized by profound delirium, extreme agitation, severe autonomic nervous system instability, like excessive sweating and dangerously high blood pressure, a low-grade fever, and profound diaphoresis, or sweating.
The major objective of drug therapy during withdrawal is to prevent these most life-threatening complications: seizures, delirium, and arrhythmias. Electrolyte balance, particularly potassium, magnesium, and phosphate, should be restored rapidly, consistent with renal function. Thiamine therapy is initiated in all cases to prevent Wernicke-Korsakoff. Individuals in mild alcohol withdrawal might not need any other pharmacologic assistance, just supportive care and monitoring.
But for more severe cases, detoxification involves two key principles. First, substituting a long-acting sedative hypnotic drug for alcohol to calm the hyperexcitable nervous system, and then gradually tapering its dose to allow the body to readjust safely without extreme shock.
Benzodiazepines are the preferred class of drugs due to their wide safety margin in this context and their ability to enhance GABAergic neurotransmission, effectively boosting the brain's brakes. Long-acting benzodiazepines like chlordiazepoxide and diazepam have the advantage of requiring less frequent dosing, and they're slowly eliminated. Pharmacologically active metabolites provide a built-in tapering effect, smoothly reducing the drug's presence over time. However, a potential disadvantage is that they may accumulate, especially in patients with compromised liver function, potentially leading to oversedation.
Exactly. For patients with liver disease, shorter-acting drugs like lorazepam and oxazepam are preferred because they are rapidly converted to inactive water-soluble metabolites that do not accumulate, making them particularly useful and safer in this vulnerable population. These can be administered orally for mild to moderate cases, or parenterally, meaning intravenously or intramuscularly, for patients with more severe withdrawal reactions requiring faster or more reliable absorption.
Crucially, after acute withdrawal treatment, these benzodiazepine medications must be tapered slowly over several weeks to prevent rebound hyperexcitability and further withdrawal symptoms. Complete detoxification is not achieved with just a few days of alcohol abstinence. In fact, several months may be required for full restoration of normal nervous system function, especially sleep patterns, which can remain disturbed for a long time.
Once detoxification is complete, the journey for someone with an alcohol use disorder is far from over. Psychosocial therapy, whether it's in intensive inpatient or outpatient rehabilitation programs, becomes the primary and most vital treatment for long-term alcohol dependence. It's about addressing the behavioral, psychological, and social aspects of the disorder and building coping mechanisms.
What's particularly important here is the interplay with other mental health conditions. Coexisting psychiatric problems, most commonly depressive or anxiety disorders, are very frequent in individuals with alcohol use disorder.
Yeah.
If these co-occurring conditions are left untreated, they can significantly contribute to relapse, undermining all recovery efforts. Therefore, treating these associated disorders with appropriate counseling and medication can profoundly help decrease relapse rates and improve overall outcomes.
Beyond therapy, 3 drugs currently have FDA approval as adjunctive treatments for alcohol dependence, meaning they're used in conjunction with psychosocial therapy to improve outcomes. Let's really dive into them.
First, naltrexone. Naltrexone is a relatively long-acting opioid antagonist, meaning it effectively blocks mu-opioid receptors in the brain.
So what does this all mean for someone recovering from alcoholism? Clinical trials have shown that naltrexone, both when used alone and combined with behavioral counseling, reduces the rate of relapse to drinking or alcohol dependence. It also helps reduce craving for alcohol, especially in patients who adhere well to treatment. This suggests that by blocking the opioid reward system, it helps diminish the pleasurable effects of alcohol and therefore the intense desire to drink.
It's FDA approved and available as a daily oral dose of 50 milligrams, or as an extended-release intramuscular injection administered once every 4 weeks, which can be very helpful for improving patient adherence. However, there are important considerations. It can cause dose-dependent hepatotoxicity, meaning liver damage, so caution is needed in patients with elevated liver enzymes, and liver function should be monitored. The combination of naltrexone and disulfiram should also be avoided, as both are potential hepatotoxins, increasing the risk of liver injury.
Crucially, if a patient is physically dependent on opioids, naltrexone will precipitate an acute and severe opioid withdrawal syndrome. So they must be opioid-free for a period before starting naltrexone therapy. It also blocks the pain-relieving effects of typical opioid doses, which is an important consideration if a patient on naltrexone requires pain management for another condition.
Second, acamprosate. Acamprosate has been used in Europe for many years and is also FDA approved for alcohol dependence.
Its exact molecular effects are complex and still not fully understood, but they are thought to involve actions on multiple neurotransmitter systems, including GABA, glutamate, serotonin, noradrenergic, and dopamine receptors. Its best characterized actions are as a weak NMDA receptor antagonist, dampening excitatory pathways, and a GABA receptor activator, enhancing inhibitory pathways. This suggests it helps normalize brain activity that has been dysregulated by chronic alcohol use, particularly during the protracted abstinence phase.
In European clinical trials, acamprosate demonstrated a reduction in both short-term and long-term, meaning more than 6 months, relapse rates when combined with psychotherapy. However, in a large American trial known as the COMBINE study, it did not show a statistically significant effect when used alone or even in combination with naltrexone, highlighting potential differences in patient populations or study design and the complexities of addiction treatment.
It's typically administered as 1 or 2 enteric-coated 333 milligram tablets 3 times daily. It's poorly absorbed from the gut, and food further reduces its absorption, so it's usually taken on an empty stomach. It's widely distributed and primarily eliminated through the kidneys, with no apparent significant drug interactions. Common side effects are usually gastrointestinal, including nausea, vomiting, and diarrhea, as well as rash. It should not be used in patients with severe renal impairment due to its renal elimination.
Third, disulfiram. Disulfiram works by directly inhibiting aldehyde dehydrogenase, the very enzyme responsible for breaking down the toxic acetaldehyde.
This mechanism causes that extreme discomfort we discussed earlier: facial flushing, a throbbing headache, severe nausea, vomiting, sweating, hypotension, and profound confusion, all occurring within minutes of consuming alcohol and lasting from 30 minutes to several hours. The idea, quite dramatically, is to create a highly aversive reaction to deter any drinking.
Despite this dramatic effect, disulfiram is rarely used today. This is largely due to low patient adherence. It's incredibly difficult for individuals to consistently take a medication that causes such severe reactions if they drink. Furthermore, evidence from clinical trials for its effectiveness in promoting long-term abstinence when compared to other treatments is somewhat weak.
It's rapidly absorbed from the gastrointestinal tract, but its full action takes about 12 hours to develop. Its elimination is quite slow, and its effects can persist for several days after the last dose due to its irreversible inhibition of ALDH. It can also inhibit the metabolism of other drugs like phenytoin, oral anticoagulants, and isoniazid, potentially leading to increased levels and toxicity of these medications. It should not be taken with any alcohol-containing medications, even non-prescription ones. It can cause small increases in liver enzymes, and its safety in pregnancy has not been established.
While these 3 drugs are currently FDA approved, the research continues for other promising drugs that could aid in long-term recovery, though they are not yet FDA approved for this specific indication. Several other drugs have shown efficacy in maintaining abstinence and reducing craving in chronic alcoholism. This includes anti-seizure agents like topiramate, gabapentin, and valproate, as well as baclofen, which is a GABA receptor agonist.
Studies also indicate that varenicline, a nicotinic agonist primarily used for smoking cessation, can reduce binge drinking in mice, suggesting a potential broader role in addiction. While selective serotonin reuptake inhibitors, or SSRIs, and ondansetron, a 5-HT3 antagonist, haven't shown overall positive results in trials for alcoholism, they may benefit specific subgroups of patients, highlighting the increasing need for personalized medicine in addiction treatment.
Based on findings from those model systems we discussed, research is actively exploring agents that modulate cannabinoid CB1 receptors, corticotropin-releasing factor receptors, and other GABA receptor systems, among several other possible targets. Rumonabant, a CB1 receptor antagonist, for example, has successfully suppressed alcohol-related behaviors in animal models and is currently being tested in clinical trials for alcoholism. Cannabidiol, or CBD, and spironolactone also show promise from recent positive studies in both animal models and preliminary clinical trials, indicating exciting future directions for treatment development.
While ethanol is the alcohol we commonly associate with consumption, other alcohols, primarily used as industrial solvents, can cause severe and often fatal poisoning if ingested. Methanol and ethylene glycol are two of the most frequent culprits in such intoxications, and it's vital to distinguish them from ethanol poisoning.
Isopropyl alcohol, more commonly known as rubbing alcohol, is another alcohol sometimes ingested when ethanol isn't available. It causes coma and significant gastrointestinal irritation, leading to intense nausea and vomiting. However, it generally isn't associated with the specific retinal damage or severe kidney damage seen with methanol or ethylene glycol, making its toxic profile distinct. It's still dangerous, but the long-term consequences are different.
Let's delve into methanol, also known as methyl alcohol or wood alcohol, the blindness and death toxin. Methanol is widely used in the industrial production of synthetic organic compounds and as a constituent of many commercial solvents. In the home, methanol is most frequently found in products like canned heat or windshield washing fluid. Tragically, poisonings often occur from accidental ingestion of methanol-containing products or when it's mistakenly used as an ethanol substitute, often in illicitly produced alcoholic beverages.
It can be absorbed through the skin, respiratory tract, or gastrointestinal tract and distributes throughout the body's water. What's crucial here is that methanol itself isn't the primary toxin. The primary mechanism of its elimination in humans is its oxidation to formaldehyde and, critically, to formic acid, which then further metabolizes to carbon dioxide and water. This is shown in figure 3.
So what does this all mean for human susceptibility? Human susceptibility to methanol toxicity is due to this metabolism. Different animal species show great variability in their mean lethal doses, but humans are particularly vulnerable because we efficiently convert methanol into these highly toxic metabolites, specifically formic acid. Because this conversion to toxic metabolites is relatively slow, there's often a significant delay of 6-30 hours before severe toxicity appears, making early diagnosis challenging. Patients might initially seem only mildly intoxicated.
Early physical findings are often nonspecific: general inebriation, gastritis, and an elevated osmolar gap, which is a laboratory finding indicating the presence of unmeasured solutes in the blood. In severe cases, a distinctive formaldehyde odor may rarely be present on the breath or in the urine, though this is uncommon.
But after that crucial delay, the most characteristic and devastating symptom of methanol poisoning appears: visual disturbance, often described by patients as like being in a snowstorm or having blurry vision. This can rapidly progress to permanent blindness due to direct damage to the optic nerve. This visual impairment comes along with severe anion gap metabolic acidosis, where the blood becomes dangerously acidic due to the formic acid buildup.
Signs of poor prognosis in methanol poisoning include bradycardia, or a slow heart rate, prolonged coma, seizures, and acidosis that is resistant to typical treatment. The ultimate cause of death in fatal cases is sudden cessation of respiration. A serum methanol concentration above 20 mg/dL warrants immediate treatment, and above 50 mg/dL is considered serious enough to require hemodialysis. While serum formate levels are a better indicator of pathology, they are not widely available in most clinical settings.
Now let's discuss the treatment of methanol poisoning. The first step, as in all critical poisonings, is immediate supportive care for respiration and basic life functions.
Beyond that, there are 3 specific treatment modalities for severe methanol poisoning. 1. Suppression of metabolism by alcohol dehydrogenase. This is absolutely key because ADH is the enzyme that converts methanol to its toxic products, formaldehyde and formic acid. If we can inhibit this step, we effectively prevent the formation of the poisons.
Right. There are 2 main ways to do this. Fomizole, this is an ADH inhibitor, and it's approved specifically for both methanol and ethylene glycol poisoning. It's given intravenously with a loading dose than regular doses, Fomisol. Interestingly, the dose needs to be increased after 48 hours because Fomisol rapidly induces its own metabolism by the cytochrome P450 system, meaning the body starts to break it down faster. Patients on hemodialysis require even more frequent dosing. It's generally safe with mild side effects. Intravenous ethanol. This is an alternative to Fomisol, and it works on the same principle. Ethanol has a much higher affinity than methanol for ADH, meaning the enzyme prefers to bind to ethanol, intravenous ethanol. By saturating the enzyme with ethanol, we effectively reduce the production of toxic formate from ethanol. However, because ethanol's metabolism is dose-dependent, frequent monitoring of blood ethanol levels is crucial to ensure therapeutic concentrations are maintained, which can be logistically challenging.
2. Hemodialysis. In severe cases, hemodialysis is used to directly eliminate both methanol and its toxic metabolites, particularly formic acid, from the blood. This is a rapid and highly effective way to remove the poisons.
3. Alkalinization. Due to the profound metabolic acidosis caused by formic acid, treatment with intravenous bicarbonate is often necessary to raise the blood pH to a safe level. Additionally, folinic and folic acid are often administered because folate-dependent systems are responsible for oxidizing formic acid to carbon dioxide in humans. While this strategy makes biochemical sense, its clinical efficacy hasn't been fully tested in studies.
Let's move on to ethylene glycol, the kidney damager. Ethylene glycol, another polyhydric alcohol, is commonly found in antifreeze and industrial solvents. Children and animals are sometimes tragically attracted by its sweet taste, leading to accidental ingestions. It can also be ingested intentionally as an ethanol substitute or in suicide attempts.
Similar to methanol, ethylene glycol itself is relatively harmless and is primarily eliminated unchanged by the kidney. However, its metabolism to toxic aldehydes and, critically, to oxalate causes the severe damage. These metabolites are the true culprits responsible for its widespread toxicity.
What's particularly fascinating here is that ethylene glycol overdose presents in 3 distinct stages, making prompt diagnosis and intervention critical at each phase. Within the first few hours, there's a transient period of excitation followed by central nervous system depression, mimicking simple alcohol intoxication. After a 4-12-hour delay, severe metabolic acidosis develops due to the accumulation of acidic metabolites and lactate as the toxic byproducts build up. Finally, usually days later, oxalate crystals begin to deposit in renal tubules, leading to delayed renal insufficiency and permanent kidney damage.
The key to diagnosis is recognizing the combination of anion gap acidosis and osmolar gap and the presence of oxalate crystals in the urine. Crucially, this presentation occurs without the visual symptoms characteristic of methanol poisoning, which helps clinicians differentiate between the two toxic alcohol ingestions.
As for the treatment of ethylene glycol poisoning, it shares significant similarities with methanol poisoning. Early administration of Fomisol is the standard treatment with similar dosing protocols.
Intravenous ethanol is also an alternative, working on the same principle of competing for alcohol dehydrogenase to prevent the formation of toxic metabolites. Hemodialysis effectively removes ethylene glycol and its toxic metabolites and is recommended for high serum concentrations, significant metabolic acidosis, or significant renal impairment. Interestingly, the widespread use of Fomisol has actually reduced the need for hemodialysis, especially in patients with less severe acidosis and intact renal function, highlighting its effectiveness as a frontline treatment. #outro.
Wow, we've just taken an incredible deep dive into the complex and often perilous world of alcohols, from their ancient origins as a dietary staple to the intricate pathways of their metabolism and the profound, often devastating effects they have on virtually every organ system in the body.
We've explored the complex mechanisms of acute intoxication, understanding precisely how a seemingly simple substance can lead to central nervous system depression, respiratory collapse, and even death, as tragically illustrated by our freshman case study. We've also dissected the multifaceted consequences of chronic consumption on the liver, nervous system, cardiovascular system, blood, endocrine system, immune system, and even cancer risk. Understanding these mechanisms down to the molecular level is crucial for grasping the why behind the clinical picture and effectively treating these conditions. You now possess a comprehensive understanding, indeed, like an elite professional in this field.
And we didn't just stop there. We delved into the life-saving management of acute intoxication and the often challenging alcohol withdrawal syndrome, understanding the critical time courses and pharmacological interventions that stabilize the brain and body. We also covered the fascinating, if still evolving, world of pharmacotherapy for alcohol use disorder, from naltrexone and camprosate to other promising new agents. Plus, we distinguished the unique dangers and specific life-saving treatments for other highly toxic alcohols like methanol and ethylene glycol. This knowledge can quite literally save lives.
This deep dive, with its comprehensive detail and focus on the underlying mechanisms, should truly equip you to master this information, and it raises an important question for you to ponder. Given the detailed pharmacological understanding we now have about alcohol's harms and the specific ways treatments intervene, what broader implications does this knowledge have for how society addresses addiction, public health policies, and even personal responsibility in a world where alcohol remains so deeply embedded in culture and daily life?
We hope this deep dive has given you a truly invaluable shortcut to being well-informed, sparking even more aha moments, and a greater appreciation for the immense complexity of the human body and the substances we introduce to it.